Hi, I'm Stacy Hunter from LMU DCOM. There's some slides by Allie, so I thought I'd give her some credit. This is part 3 of 3 for the MGA Exam 3 section on pelvis and lower limb. Okay, so we're going to go ahead and talk about the foot. So we're going to start with the rear foot. It has our tarsals. So we've got our talus and our calcaneus. Then we have our midfoot. Our forefoot consists of our metatarsals and then our phalanges. So as you'll notice, we had metacarpals and then we also had phalanges in our hand. So this is very similar to our hand. And the most distal part, of course, is going to be our phalanges. And just like in the hand, we've got proximal, middle, and distal phalanges. The dorsal portion of our foot is going to be located what we would consider as the top of our foot. And then the plantar aspect is going to be where the arch of the foot is located. And it's going to be the part that would be like touching the floor. Okay, so looking at the foot osteology, it's really important to be able to know what all of the bones of the foot are and where they're located. So if we start looking at the bones of the foot, an easy way they could ask this question is like they show you an x-ray and point to one of the bones and say, okay, what bone is this? So a way of remembering this would be tiger cubs need milk. So it's talus, tiger, cubs, calcaneus, need, navicular, and then M-I-L, and then cuboid's the last C. I think this is kind of confusing since it sort of jumps around. So the way I think about it is the actual definition of navicular, which deals with ships. So I think of it kind of looks like a ship. And then we've got our 3 cuneiforms, and they're located like inside our ship if the foot is pointing upwards. So here's our little people in our ship. And then the great one, or our great toe, is looking down on our ship, on our navicular. The only one left is cuboid, and it's over on the lateral aspect, and it kind of is a cube shape. So something else to know is tibialis posterior and fibularis longus, the way that they pull creates this transverse arch. And we're going to talk about their actions in a few minutes. But to go back and review, since we are on this slide, tibialis posterior is going to invert the foot. And then fibularis longus, it's going to pull toward our fibula. So that's going to pull laterally. So that is going to evert our foot. These sesamoid bones, they can be located on the 5th digit as well as the 1st, but it's more commonly on the 1st, and there's usually 2. So these are not like, if you look at these on an x-ray, somebody might think that they broke off of the foot, but they're very round in shape, and these are just accessory bones that formed and help guide those tendons and make sure that they don't stray. Okay, ligaments of the ankle. These are super important. So let's start with the medial ligament of the ankle. So this is the deltoid ligament, and you don't have to know that the really good thing about the medial ligaments is that usually they just call it the deltoid ligament. They don't go into all of the different names of it. So tibionavicular, if you take each of these names, you can actually see what they actually go to. So we're going from the tibia to the navicular. So that's tibionavicular. We've got anterior tibiotalar. We have posterior tibiotalar, and then tibiocalcaneal. So all of these make a delta shape or a triangle. So that's why it's called the deltoid ligament of the ankle on our medial side. On the lateral side, these are more important that you need to know their names. And so we've got an anterior talofibular and a posterior talofibular. We also have calcaneofibular. So I sort of think of it, we've got our fibula down and we need to attach it on 3 sides. So we're going to put attachment in the front, anterior, and it's going from the talus down to or from our talus up to our fibula. Then we've got another one going down that is calcaneo. Here's our calcaneus to our fibula. And then we've got the posterior talofibular. We also have inferior and anterior posterior tibiofibular, so we've got some ligaments that go in between our fibula and our tibia. But these 3 make up the lateral ligaments of the ankle. And the fun thing about this anterior talofibular, it's the one in a ankle sprain is the one that always tears first. So we have A, anterior, T, talo, and then fibular, ATF. And that's what it's usually referred to as. So our ATF also stands for always tear first. This posterior ligament is the posterior tibiofibular, and it's also just attaching these 2 bones together. And you can see in this picture that we've got the medial and the lateral ligaments as well. Okay, so let's talk more about ankle sprains. So we'll start with this low ankle sprain. So if somebody jumps and they land wrong, again, this anterior talofibular ligament is the first one that's most likely going to tear. So when you're thinking about, okay, am I inverting or am I everting to make an ankle sprain and which one is going to affect, you have to think, so this person is inverting their foot. That means that they're creating more of a space on the outside of their foot. The inside of their foot is coming closer together. So that ligament is not going to be hurt or torn, but this outer portion is going to be drawn more apart. So since that's the case, the ligaments can tear. So I know if I'm going to invert, bringing the inside together but the outside apart, I know that the outer portion, that lateral portion, is what's going to have the strain. And that's also the portion that is going to resist that inversion. But it gets to its breaking point and it can't resist that inversion anymore, and then it may tear. with a medial ligament tear, it's another low ankle sprain. If it's everted, it's usually from contact sports, but it's not as common as this this inversion sprain. So that eversion, it's going to get shorter and contract on the lateral aspect. The medial aspect is going to be stretched apart and could potentially break. High ankle sprain is also called syndesmosis sprain. We had talked about the tibiofibular ligaments. There's anterior and posterior ligaments. So it's associated with fibular fractures, usually at the head of the fibula. But these ankle sprains can not only just affect this low ankle, but if this is torn apart, it's going to be a high ankle sprain because it's going to also affect the top of the tibia and fibula located at the knee. Okay, so let's look at this ankle joint cross section. The tibia onto the talus is the talocrural joint, and that is what we consider our ankle joint. It's what causes dorsi and plantar flexion. Over here on the side from our tibia and our talus on the medial aspect is this deltoid ligament of the ankle. On our fibular side, or our lateral side, we've got our posterior and anterior talofibular ligament, as well as our calcaneofibular ligament. So make sure that you look, okay, I've got a fibula, so I know it's the lateral aspect, and then I've got a tibia and no fibula on that side, so I know that's the medial aspect. And so if they were to point, let's say, over here at an x-ray and say that, a patient hurt their ankle where it's torn, and they put an arrow right here, you're going to think, okay, let's look at the tibia, let's look at, okay, I know there's no fibula over here, so maybe they've torn their deltoid ligament. This subtalar joint, we've talked about the talocrural joint, but the subtalar joint helps with inversion, eversion along that transverse tarsal joint. Make sure that you are able to identify, mostly from this picture, the ligaments and know which side is lateral and which side is medial. Here's looking again at some of the plantar ligaments. So we've got a long plantar ligament, and then we've got this spring ligament, or the plantar calcaneonavicular ligament, located to the calcaneus to our navicular. And then also our plantar calcaneocuboid, from the calcaneus to the cuboid, which is also called our short plantar ligament. Many times these are referred by their other names, so the long plantar, short plantar, and spring versus the anatomical name. So make sure that you know both. Okay, so let's look at the dorsal foot. So we've talked about the posterior tarsal tunnel, but here's our anterior tarsal tunnel, and it's going under this superior-inferior extensor retinacula. So we had talked about some retinacula when we were talking about the wrist. So this is very similar on the foot. So we had talked about the arteries. So this dorsalis pedis artery is what seldom people end up feeling to see if there's a pulse. And so like on babies, instead of waking a baby in the hospital, oftentimes they'll go and feel this dorsalis pedis pulse and not have to wake the baby and make sure that they have good pulses. And also to make sure that perfusion gets down to the feet. Beside dorsalis pedis is where the deep fibular nerve travels, and if it's entrapped, it can cause this anterior tarsal tunnel syndrome. So if you think about the actions of the deep fibular nerve and think, okay, well, it's in the anterior portion of the leg, actions that the anterior aspect does may be affected. So something that would be affected would be extension of the toes, for example. So these are also what are innervated by the deep fibular nerve that's located down in the portion of our foot. So we've got our extensor hallucis brevis, and it's going to our big toe. So the big toe is our hallucis, and then we also have our extensor digitorum brevis. So if you see brevis, it's usually short and it's located only in the foot, so it's not going up to the leg. Okay, so let's look at the plantar aspect of the foot. So we've got this big sheath and this plantar aponeurosis. So when you're looking, there's a lot of fat at the bottom of the foot. So if we didn't have that fat, we would have all of that weight of our body down pretty hard down onto bones, and that would start hurting. So there's a good layer of fat on our feet so that we don't have that painful sensation. Then we've got this plantar aponeurosis that's really thick connective tissue, and sometimes people have pain located from their heel to the bottom of their foot, sort of at their arch, and that's called plantar fasciitis. And so that's where the plantar aponeurosis gets inflamed. Here's another sheath located around our toes, which is our fibrous digital, so digits, sheath. At our foot, let's start at the bottom. We start with our tibial nerve, and that's going to branch into our lateral plantar, going to the lateral aspect of our foot, and then the medial plantar. So remember, that's coming off of our tibial nerve, which is located on the posterior aspect of the leg. From our medial plantar, we're going to branch up into the common plantar and then the proper plantar as we get to our toes. On this lateral side, we're going to have a deep branch, and we're also going to have some superficial branches. So as you can see right here, this portion is going to be, of our foot, is going to be innervated by the medial plantar, and this gold portion is going to be innervated by the lateral plantar. So if someone were to have paresthesia to this aspect, you would know that it was the lateral plantar that may have been cut. That superficial nerve of the leg, the sural nerve, that is going to be on the lateral aspect of the foot, sort of near the heel. And then the saphenous is going to be on the more medial aspect, and then tibial is going to be located on the heel itself. So now I'm going to show the layers of the foot. So our first layer is going to begin with these abductor digiti minimi and abductor hallucis. So just like in our hand, we've got the abductors on the outside portions, abducting now our toes. So our hallucis is going to be the big toe side. So it's going to be located right here. And here's our abductor digiti minimi. On the more medial, or on the inside portion of the foot, there's the flexor digitorum brevis, and so it's coming from our calcaneus up into each of these digits to flex the toe. On our second layer, we're going to add the lumbricals. We've got our lumbricals 1 and then 2 through 4, and so these are going to be color-coded based on their innervation. So abductor digiti minimi is going to be that lateral plantar. The medial plantar nerve is going to be those lumbricals 2 through 4, as well as the flexor digitorum brevis and abductor hallucis. And then the lateral plantar nerve is going to be for lumbrical 1 and then the quadratus plantae. So the lumbricals, remember, just like in the hand, but this is slightly different with the foot, it's going to be located on those tendons of our flexor digitorum longus. This quadratus plantae is sort of it's really hard to see in lab, but it's a rectangle shape and it's located on that plantar aspect and very deep. Okay, let's add another layer. So this adductor hallucis longus is what creates that 7 shape. And again, to remind us of our color coding, that golden color is our lateral plantar nerve. So this adductor hallucis longus is going to be part of our lateral plantar nerve, and that's going to be innervated by that lateral plantar nerve. And it's got a transverse and oblique head. This flexor digiti minimi, so we had our abductors on the outside, and then our flexors located just inside of that. It's also, again, that lateral plantar nerve, the superficial branch, where this is the deep branch. Then the flexor hallucis brevis, it's going to be right inside, right beside that abductor, and it is innervated by the medial plantar nerve. Our interossei, they're going to be innervated by the lateral plantar nerve, and then the dorsal interossei, they're going to be located, they're also innervated by the lateral plantar nerve. So this is unipentate, as you can see there one side, where these are bipentate, so you can see that they're located on 2 sides. So remember, we've got our pads and our dabs. So plantar interossei, adduct, dorsal interossei, abduct. Okay, so here's a summary of all of the layers of the foot. I don't think that it's super important, or they'll ask you, for instance, what the layers are. It is important to know what is more deep than what's more superficial, but absolutely be able to look at the bottom of a foot and be able to identify where these muscles are and also what innervates them. Okay, here's our arterial supply of the foot. So here's this dorsal pedis that we've talked about. Remember, that's coming from our anterior tibial. We've got our arcuate making an arc. And then this is our lateral tarsal that is anastomosing with this arcuate, as well as our dorsalis pedis. To our toes, we've got down our dorsal metatarsals and then our dorsal digitals when we get to the digits. On this plantar side, we've got a deep plantar arch that had come from the lateral plantar. Our medial plantar is coming up along the medial aspect, and it's not going directly into that arch, but it's going farther up to that MTP joint and going to make the plantar metatarsals and then to the plantar digitals. And then it's coming back down to anastomose with a deep plantar arch. So let's talk about the gait cycle. So the goal of an efficient gait is to maintain that center of gravity. So if our center of gravity is off, then we may not be able to stand up straight. So it's going to change a little bit due to gaining weight, different neurological abnormalities, injuries, for example. And so something like pelvic rotation, it's going to maintain a center of gravity by lengthening that limb. So if you walk and you pick up one leg, it's going to help move and maintain that gravity by moving your gravity over to that other limb. Then hip adduction, it's going to minimize that lateral shift from where you had adducted the hip. Knee flexion is shortening the limb, and then pelvic tilt or an abduction is minimizing that droop. So if you hear of eccentric, that's going to be a lengthening, and concentric means shortening. If there's a closed chain movement, that's foot in contact with the ground, as opposed to open chain where it's not in contact with the ground. So the way I sort of think about this and maintaining center of gravity, it comes more important next year in MSK. But what I like to think is, okay, if I, for some reason, didn't have my quads, how would I be able to maintain that center of gravity? People end up having to move their center of gravity in more forward or past their limitation. So if somebody has a quad problem, their quads don't work, they're going to have to lean more forward in order to be able to maintain that center of gravity. And so they'd be walking with stooped forward. If someone, for example, had a problem with their gluteus maximus, then they would start leaning backwards to maintain that gravity. So let's just talk a little bit about the normal gait cycle. So we're going to start out with stance phase. And I think the easiest way to actually do this is using your body yourself. So anytime I approach a gait cycle question on an exam, you may not be able to stand up and walk around. That's understandable. But in your chair, you can make like this heel strike, initial contact. And I think, okay, if I'm moving my toes up, what's having to contract? What do I feel? And so if I go through this whole cycle and move my leg beside my chair, I can end up knowing what muscles actually are affected. So let's start with the heel strike. So we've got this heel strike. So I'm having to pull my toes upwards, or dorsiflexing. That's going to be caused by tibialis anterior. That anterior compartment is going to be dorsiflexing my foot and toes. Also, my hip extensors are going to start working, and that is glute max. So we're trying to preserve that longitudinal arch. The next thing, I put my toes down, and that is going to be the loading response. So my foot is going to be flat. It's going to be accepting the weight. So my quads are going to contract, as well as the back of my leg, and that's going to be my calves. So my knee extensors, the quads, they're going to be affected. And then the plantar flexors, which is the triceps surae, they're also going to be what's affected. And you can see that from this picture, and I think it helps with the picture. The hip abductors, glute minimus and medius, are also important in this loading response. Mid stance, I've got my knee straight, and what's going to be happening is I need to be able to stabilize the pelvis, stabilize the knee, so our hip abductors, our knee extensors. But what's most important is controlling that dorsiflexion. So that triceps surae is what's going to be most affected. So let's move over to the acceleration point. So we've got this push-off phase. So we've already stood, and now we're going to push our toe off. So we need to be able to, again, stabilize the pelvis and then be able to lift the heel. So lifting the heel is that contraction of our plantar flexors, which would be the triceps surae. And it's preserving those foot arches. After that, we've got our pre-swing phase. So we're starting to bend the knee and about to be able to take our foot off of the ground. So we're going to accelerate the mass, which is our digital flexors. We're going to deaccelerate the thigh, which is a contraction of our hip flexors, which would be our rectus femoris, which is right here, and then preserve those foot arches. So what's most important about the hip swing is that we're getting those quads working, especially rectus femoris. So just in case that somebody might be confused what triceps surae is, that would be the muscles that attach down onto the calcaneus, onto our and make up our Achilles tendon. So the ones that would do that would be the two heads of our gastrocs, and then also our soleus. And then plantaris would be part of that as well. So the last portion is the swing phase. So our foot is going to come off of the ground, and now we're going to start swinging our leg forward to start again at the beginning again. So the front and back of the thigh is going to be engaged. So we're going to accelerate the thigh using our rectus femoris. Our knee flexion is going to be due to the hamstrings. So you're going to have to flex the knee, but you have to bring this forward, so you're using both sides. And then being able to clear the foot is due to that tibialis anterior. So if they ask a question about the person during mid-swing ends up dragging their toe, that's because they can't get their toe all the way up and can't dorsiflex enough, so it might be a problem with tibialis anterior. And another way that they could also make it maybe a slightly harder question is say, okay, what's the innervation of that muscle? So the innervation of that muscle, of course, is the deep fibular nerve. And again, we're going to have that contralateral hip abduction preventing that hip drop, and we're going to talk about hip drop in a second. The very last portion is that terminal swing. So it's using almost everything, it seems like. And so we're going to decelerate the thigh using our extensors, decelerate the knee with our hamstrings, position the foot, tibialis anterior, and be able to extend the knee to the quads. So the most important are hamstrings, tibialis anterior, and the quads. So just be able to walk through it and be able to know each muscle. These are pretty simple as far as like knowing, okay, heel strike. You basically would know what part of the gait cycle that is, what loading is, mid stance, terminal stance, pre-swing, initial mid-swing, and then that terminal swing. Just make sure you know what part of the gait cycle each of these terms are, and then be able to know what the muscles are. So we've got some gait abnormalities. So there might be circumduction with a hemiplegic or stroke, And so the person is going to take their foot and sort of swing it around the other foot. Another one in like Parkinson's is a universal, they're going to be flexing, and then they're going to be taking hurried small steps. In cerebellar ataxia, and you're going to go more over that when you're talking about the cerebrum in neuroanatomy in the spring, but it's more of an uncoordinated wide stance, more of a drunk walk. Sensory ataxia, it sort of sounds like what it would be. So they're taking these steps down because they don't have good sensation. So it's kind of like Frankenstein-like walk, and it's worse in the dark. And so they're having to feel and making sure that, okay, I can put my weight down because they don't have great feeling in their foot. And then analgesic gait is just walking against the pain. So it's going to be shortening the stance on that affected side. So this person, for example, would have pain located on this side. If there is a superior gluteal nerve that's going to be affecting the abductors of the thigh, which is our gluteus medius and minimus, as well as tensor fascia lata, more than likely they would talk about either gluteus medius or minimus. And so this injury may present with this Trellenberg gait. So this gait is really odd looking, and that's something that's really highly tested because it's so different. And they want you to know that what muscles actually, and what nerve, the superior gluteal nerve, is affected. So you get this gluteal gait or waddling gait. And what's also important to know is that it's going to have a contralateral hip drop. So the trunk is going to lean toward that affected side. So for example, we've got the drop of the hip located right here. This is their left side. So they're going to be having that hip drop on the left. And so their right hip is going to be higher, but it's this right gluteus medius, gluteus minimus that's going to be affected. And then the person is going to try to be able to raise this by trying to lean toward that right side. With the common fibular nerve, it may be due to injury at the neck of the fibula, and they may have foot drop, waddling gait, swing out gait, or steppage gait. So in foot drop, the toes are not clearing the ground during that swing phase, so they can't dorsiflex. So this one is really important to be able to know. Another one that is more important to know would be the steppage gait. So they're stepping forward, and a lot of times, like in questions, they will say, this person has a steppage gait, what nerve is injured? And so that would be common fibular. Or it says, where would a fracture most likely be located? So that would be the neck of the fibula. Okay, so let's talk about some embryology. So we've got this ectoderm, as we've talked about before, having this neural tube with leading to motor neurons, and then the neural crest leads to the sensory neurons. And then we also have our epidermis. So our mesoderm, we're going to have the axial and paraaxial, and then intermediate portion, and then also the lateral plate. So the axial is going to form this notochord and the nucleus pulposus. Our paraaxial is going to end up forming somites. And then our intermediate is going to be forming those Golgi organs. And then the lateral plate, which we had talked about in second block, is going to consist of somatic and splanchnics. So we get, from the somatic, we get our limb buds, and then from the splanchnics, we get our endoderm-lined organs and our cardiac muscle. So there, again, is a limb rotation. So rotations are always really important. So the upper limbs are going to rotate laterally at 90 degrees. So the flexors are going to be anterior and the extensors are going to be posterior. And then if you think about the lower limbs, we've got our extensors that are anterior and our flexors are posterior. So they're going to rotate in the opposite direction. They're going to rotate 90 degrees medially. So be able to distinguish the 90 degrees lateral versus medial rotation and know if it's upper or lower limbs. Okay, so let's talk about the somites. So we've got the scleroderm, dermatome, and myotome, and that's what's dividing our somites into three parts. So the sclerodome is going to be via the endochondral ossification, so our vertebrae and ribs, which we're going to talk about in a minute. Our dermatome, we talk about dermatomes, and so that's our skin, our dermis, and the innervation there. And then our myotome, it has myo in it, so that's going to be skeletal muscle. So each myotome has one spinal nerve. Our myotome can then be split into epimere and hypomere. So epimere is epiaxial and hypomere is hypaxial. So the hypaxial is going to be innervated by the anterior rami of the spinal nerves, where the epaxial is going to be innervated by the posterior rami. So that's forming our dorsal body wall muscles, where our hypaxial is forming the ventral body wall muscles and our limb muscles. Those limb muscles we're going to condense down. We've got an anterior and posterior condensation of our upper extremity. So the anterior is going to form flexors and pronators, and then the posterior is going to form the extensors and supinators. The lower extremity, we've got our anterior condensation, which is going to be flexors and adductors, and then posterior is going to be extensors and abductors. So just make sure that you can distinguish between the upper and lower extremity, and you can distinguish between epaxial and hypaxial and what they're innervated by. Okay, so we've got the endochondral ossification. So we've got the sclerotomal. So that's going to be migrating to our spinal cord, and it's going to be segmented. And so this is what's forming our vertebrae. So sclerotomal is forming vertebrae. Precartilaginous is dividing into cranial and caudal sections. And so the cranial sections fuse with the adjacent caudal section, where the spinal nerves pass between those vertebral bodies. And then we've got cartilaginous, which is differentiating into chondrocytes. So we've got our centrum, which is the vertebral body. We've got the vertebral arch, which is the pedicles, lamina, spinal processes, and transverse processes. And then we've got the costal processes. So cervical is going to be transverse and transverse foramen. Thoracic is going to be the ribs. Lumbar is the transverse processes, and sacral is the ala. So the bony portion is going to be the primary ossification during development. A secondary ossification occurs during puberty, and it fuses within the mid-20s. Okay, here are some congenital defects of the vertebra and ribs, and you're going to cover this more next year when you're in MSK, but there's Klippel-Feil syndrome, which is cranial caudal shifting. So there's going to be cervical vertebrae that are going to be fused, and that's usually due to this excessive retinoic acid during pregnancy. Spina bifida is going to be incomplete development of the dorsal vertebral arches. If it's closed, it's called spina bifida occulta, and that's pretty common. People may not know that they actually even have it, but it is a type of spina bifida. It's not the severe type that you usually hear about. You can actually get some extra ribs that are either cervical or lumbar. Cervical are less common, but they usually attach to C7 and they put pressure on the brachial plexus, so usually they end up have to be removed. And then there's scoliosis. So here's two different types. We've got a hemivertebrae, which is complete unilateral failure. So you can see how two of these start to form, and it didn't form this other side, and it also didn't separate. And then you've got a blocked vertebrae. So on both sides, it forms this really big vertebrae with lots of transverse processes. This is really important to know, the AER and ZPA. So AER is the apical ectoderm ridge, and it directs proximal to distal limb development, where the ZPA, zone of proliferating activity, directs anterior to posterior limb development. So both of these are really important. So the AER creates this formation of long bones, and it's not really important to know what these weeks are, per se, at least at this point. But as you can see, it starts forming hand and foot, then fingers form, then the digits start to separate. And digits separate due to apoptosis. So if there's an interruption in a malformation, either it could be due to polydactyly or syndactyly. So polydactyly is where actually extra digits are formed, and this is due to a malformation in the AER, or syndactyly, where there are webbed digits. So this is probably due to the digits not separating via apoptosis. The ZPA, we already said, directs anterior posterior limb development, and it is induced by retinoic acid. So if there's not retinoic acid during pregnancy, an excess, or if there is too much retinoic acid, an excess can cause wrong structures to form. If there's not enough, again, it can cause some other issues with that anterior posterior limb development. Here's some congenital limb malformations. So achondroplasia, which is dwarfism, is a premature ossification of the long bones at the epiphyseal plates. So it results in shortened limbs, but yet all the other body parts are normal sized. Congenital amputations. So the person is born without a limb. It may be due to tissue differentiation failure or mechanical failures. Clubfoot, maybe because of pressure from the uterine wall. Amelia, and it's important to know what these terms are. Amelia is complete abscess of limbs. So when we put an A in front of something, that means no. So there's no limbs. Meromelia is absence of limb segments. And then phocomelia is absence of proximal structures. So faux proximal. And you can see that in these pictures. So that's all I have today. If you have any questions, again, email me, and study hard for your exams.